Even if the disease is controlled, the synovitis is settling, the contracture sometimes does not improve. So these patients are good candidates for either serial casting under anesthesia or even selective soft tissue releases, which we can do quite easily as 1 or 2 day stay patients. Arthrodesis, as seen here in the knee, this is very seldom used anymore because there are better options available, but this can still be an option for a failed joint replacement procedure in a patient with rheumatoid arthritis because the bone quality is usually poor. But arthrodesis for the wrist, I still do a fair number, though with the presence of hand surgeons now, orthopedic surgeons are doing less and less wrist arthrodesis, but it's a very rewarding procedure. We normally do a synovectomy at the same time. We do tenolysis of the tendons and stabilize the wrist, ideally with a plate, metal plate, and then bone graft it. Patients normally have very stable function at the wrist since they do not lose pronation, supination, they just lose flexion extension at the wrist. But this is reserved for patients who have already lost flexion extension motion at the wrist. Fusion in a position of function, which is, as you can see, about 30 degrees of dorsiflexion, really enhances their ability to perform activities of daily living. Realignment osteotomy is a procedure which is mainly for patients with osteoarthritis. For example, varus tibial deformity, tibia vara, is very common in this part of the world. Some people think this is related to vitamin D deficiency earlier on in life, but this shifts the weight-bearing axis more from the equal on both sides to more on the medial side. This particular illustration shows an external fixation device. I personally prefer internal fixation, but this shifts the weight-bearing axis more equally, decreases pain, and it can actually delay the onset of tricompartmental osteoarthritis, which will then require joint replacements. Joint replacement arthroplasty used to be considered a procedure of last resort. Now, this is one of my patients, 47-year-old male, ankylosing spondylitis. When he presented to me, he had been bedbound since the age of 20. He was one bone basically from his skull all the way down to his toes. And if you can see, I don't know how clear this can be seen, his hips are totally ankylosed, his knees are totally ankylosed. And as he was lying down, you can see this is on the table before surgery. Most of these patients actually cannot even be intubated. They require a tracheostomy by the ENT specialist before they can be given anesthesia. So his head is a good 1.5 feet off the table. So this was the extent of his deformity. If I do not do anything for him, he will remain bedbound for the rest of his life. He underwent bilateral cemented total hip replacements followed by bilateral knee replacements, and he walked for the first time in 20 years. He is walker dependent. He'll never be independent, but he left the house for the first time in 20 years. Now this is a very clear-cut case. Nobody would dispute that I would do a joint replacement in a 47-year-old with this history. But what about this patient of mine? He's 18 years old. He just turned 18. He's a diagnosed case of juvenile rheumatoid, or as it's now better called idiopathic rheumatoid arthritis. Disease onset 6 years back, and he is now chair-bound for the last 2 years. When I saw him, he was already chair-bound. What to do? Now, standard orthopedic teaching has been to defer joint replacements as late as possible. And 15 years ago, we used to say, 40 saal ke baad aana, come back when you're 40, 45, come back when you're 60. I can't say that to an 18-year-old. Now, a standard total hip replacement in this patient would be doomed to failure because they have this issue, quality of life versus later need for revision. Now, we have to decide what is more important for the patient, to improve the quality of life or to reduce the chance of later needing a revision for a joint replacement. This does come down to the fact whether the patient is low demand or high demand. A low demand patient has been roughly measured to be someone who walks less than 1 million steps per year. And a high demand individual, a younger person, ideally would be walking more than 1 million steps per year. These have been measured by pedometers. These are not absolutely reliable parameters. This is just one way of measuring high demand versus low demand. If I put in a standard joint replacement in an 18-year-old, he would be expected to wear out his acetabulum quite quickly, develop osteolysis, and require revision before he was 25. Here is an acetabulum made of polyethylene standard total hip, which is worn through. You can see the hole there. But research has been going on for the last 45, 50 years into alternate bearings, and metal on poly hips have been replaced by metal on cross-linked polyethylene, metal on metal, and ceramic hips. So what we are now having with us, fortunately, is the presence of metal on metal bearing implants. We have metal ball articulating with the metal acetabulum, which is called hip resurfacing, and I gave this patient bilateral hip resurfacing. This was staged with a gap of about 2 weeks between the surgery, and he is now 3 years follow-up now. He has recovered his ambulation. He's walking again with a walker. Now he wants his knees to be replaced. So he's still functioning well with that. So I'll see how long he can be functional. But his hips, which were the main cause of his disability, they are now okay. He's still on disease-modifying agents. There's just a slide to show the difference between standard total hip replacement, which is now reserved for older age population, in which the head and neck is resected, versus the hip resurfacing, in which the head is just covered up with the metal cup, the metal cap, and the acetabulum is also replaced. This is our first patient in Pakistan, which we did about 5 years back. She was a 19-year-old lady with tuberculosis of the hip, and she is now having full range of motion, full and normal activity, no pain, sunborn 1.5 years after her index surgery in 2005. She is shown sitting in a praying position. We do not normally recommend patients to do this all the time, but this is a reflection as the kind of function which is now achievable in young patients with the current day orthopedic implants. This is obviously not one of my patients, but this is UK, Commonwealth and European black belt champion in karate, and he had rheumatoid arthritis and he had both hips resurfaced, and these are the medals he's won afterwards. So I'll just conclude because I think summary is quite important. I went to call the orthopedic surgeon. We are not physicians. We have to do a lot of rheumatology. We have to understand rheumatology because my full-time workplace in this hospital, we are not fortunate enough to have a rheumatologist there as yet, but we are still not physicians. The orthopedic surgeon ideally should still be involved early in the course of any type of arthritis because a lot of stuff which we can still do before the patient ends up with a joint replacement to try to delay that or defer that as much as possible. And we can help in achieving an earlier diagnosis. We can help in the differential diagnosis because with the presence of tuberculosis, it's really scary to see what would happen if patients get given wrong medication. Disease-modifying drugs I heard referred to, TNF-alpha inhibitors, were referred to as mycobacterial growth factors in the last ACR meeting in Philadelphia. So this would scale this as well. But if we can diagnose clear-cut if this patient has tuberculosis or rheumatoid arthritis, it will make treatment easy for everybody. We can decrease the disease burden. Synovectomy is a very good procedure. It is underutilized by us as well as by rheumatologists. I think we should cooperate more on that. And we can decrease the disability, improve the quality of life in patients with end-stage disease. It would be a good idea to have better disease control prior to any major surgical intervention. That would be arthroplasty. Synovectomy can be done in the presence of an active acute disease process because then it's a minor procedure, but if any patient requires joint arthroplasty, it ideally should be done with some sort of disease control being there, otherwise the complication rate is much higher. I have kept this presentation small. I will thank you for being here, inviting me here, and this being Pakistan Day, I wish best wishes to all of you and pray for the safety and prosperity of Pakistan.